Hey, folks, if you want early access to episodes as they drop, click that subscribe button, join us, and together we'll fix the broken U.S. healthcare system. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Cobra.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Cobra. I am your host, and today's guest is one of the sharpest minds in the benefits consulting world. A rare mix of legal acumen, operational leadership, and frontline healthcare experience. David C. Smith is a JD, an REBC, we're going to tell us what that is, and a partner at eBen Benefits, listen to me, a risk strategies company. He splits his time between advising large self-funded employers, ensuring airtight compliance, and much to his own chagrin, hurting producers and managing a business unit. Welcome to the big show, David.
Thank you, Ray. Glad to be here. Thanks for the invite.
No, appreciate you joining us. So it is kind of rare that you have an attorney, someone who kind of paid their dues and put in their time and worked their asses off to get through law school and then ended up in the insurance industry.
Well, kind of funny, I started on the benefits policy side, and that led me to law school because I was doing things and nobody paid attention to me because I didn't have a law degree. So I went to law school, did that at night, worked during the day for Blue Cross in North Carolina, and got it done in 4 years, and been thankful I did it, but very glad I do not practice law.
Really? Is it? So do tell, because I think a lot of kids out there, not that kids are really tuning into Broken Healthcare, but, for those that are listening that, are kind of, they have kids or nephews or nieces that are thinking about law school, it always strikes me because I remember as a regional manager with Aflac, a big piece of what I did was recruiting and bringing, new blood into the organization. And there was such a demand at the time that I used to conduct group interviews where really we would kind of lay out the opportunity and then see who had interest. And I'll never forget, a young lady came up to me with tears in her eyes at the end of my presentation because I got her all fired up. She was excited. And then I said, I say during my presentation, it is a 100% eat what you kill commission-based opportunity.
Yep.
She loved the idea of it, but she was like, I have $500,000 in law school debt. There's no way I could do this. And so I think a lot of people get into law for the right reasons. I think, they're passionate about justice and all of that stuff. But then when you come out the other side, it's like, well, do I really want to do this? And it says, I'm reading in between the lines here, David, but it sounds like you're kind of in that category where it's like, oh God, I'm so glad I'm not doing that every day.
Yeah, I tried to, I think I hated to bill. I hated to tell people what I was worth. And I think the thing that's happened over the years is I've become more confident about what I was worth, but I don't have to keep up with my time.
Yeah.
And I like the fact that I can help people and apply that knowledge without necessarily spending all this time having to track every minute of every day that I do. I would say, as it relates to law school, it gives you it definitely teaches you to think differently. But I would say more than anything else, it kind of gives you a foundation of understanding how to deal with something. I had a situation couple weeks ago with a potential E&O claim for one of my folks. And again, I wasn't negotiating it from a E&O perspective, but this person's complaining about it. I'm talking to a lawyer who I happen to know, and he's telling me, well, they did this, 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 and this. And I was like, well, you're going to lose on this front, this front, this front, this front, because this is what the law says. And so if you want to resolve this for some price less than what it costs to litigate it, we can probably figure that out. But in the meantime, all of your arguments aren't going to fly very fast because they're going to hit a wall.
They aren't going to hold water.
Yeah. And
yeah,
I think that perspective is good.
Yeah, for sure. Well, I'm a fan of the discipline that it takes to go through law school. I think it's as with anything else in life. I think it's Roger Staubach, the old famous Dallas Cowboys quarterback, is famous of saying it's the perspiration and the preparation. And so there's a lot to be said about that. And I think if you actually aspire to be a lawyer for the right reasons, hopefully, and you go through it, there's just something about that process. It's like it hardens steel, and you get out the other end. And even if you're not a practicing lawyer, I know with certainty that it has brought a level of expertise to your business that not many benefits advisors can claim.
No.
And even just being, part of a benefits organization, it's huge. It commands a certain level of respect, I think, and that goes, without saying. So you go down this rabbit hole of, well, take me from getting out of law school. Do you start practicing law? What do you do? Where do you go from there?
I stayed at Blue Cross for a couple of years and then really decided to go on my own. And I started, part of my thinking was that I would have a law firm that was really focused on helping agents, brokers, consultants, and their clients with compliance issues. And so that was a novel idea 22 years ago, 23 years ago. Nobody else was doing it. Now there's like a whole cottage industry of people who do that. But it was this idea that most agents don't know what they don't know. And if you're not prepared to help and you're not prepared to solve a problem, and HIPAA was really the beginning point of that, the idea that HIPAA is going to create a ton of stuff for clients. And then the ACA popped up and it became even more important. And I think from my end, that being a lawyer and practicing for about 6 years was really, really good for me because I got to learn how to run a business and how particularly bad I was at it, but also how much I liked the helping people. And so when I got a chance to join a friend's agency to kind of be their compliance person, and this was right before the ACA passed, it kind of almost immediately shifted into more than just that. And so when I joined eBen, I was doing really with the intent of doing compliance, and then pretty quickly got put into a couple sales meetings with prospects and realized that that other part about being a lawyer, learning body language, paying attention to what people are saying, listening, and trying to react in a way that is about building confidence and about building, finding a solution that will work for them, was something that just immediately hit me. And it allowed me to find this comfort zone where all of a sudden I could go into a sales meeting sight unseen and do okay in, because I wasn't in there to sell something. I was in there to listen and solve problems.
Yeah.
And that just kind of escalated into becoming more responsible, becoming more of a mentor to other people, becoming the guy they would take to see a big group they couldn't see otherwise, in addition to the compliance. And, then suddenly management and other things like that fell in your lap.
Yeah, for sure. So take me back, if you would, to just kind of ACA, the origins of ACA, because that really there was a lot of uncertainty, a lot of speculation. There was a promise of, a whole new world with respect to Americans' access to health care. When that bill passed and became law, I'm sure you're probably one of the few people that read it. What were your initial thoughts?
Well, I think for me, one of the really interesting points about the ACA is that there were a lot of ideas, particularly out of the Democrats in 2008, but 2009, about what they were going to do. And what's interesting, and most people forget this, is that the ACA, as it was ultimately passed in the form that ultimately President Obama proposed, was actually the outgrowth of ideas that had come from the Heritage Foundation, which you don't think, like, your automatic brain is not like, wait, the Heritage Foundation gave an idea to Obama that became the ACA. But it's true, like 2 weeks before Obama announced that was the pathway he was going to go, that was an idea on the Heritage Foundation website as a solution to healthcare reform.
And for those who might not be familiar, what is the Heritage Foundation?
So the Heritage Foundation is historically a conservative think tank and was responsible for, a lot of the ideas and a lot of the more conservative perspective on policy issues that a lot of Republicans would work from. And so as President Obama was trying to find a solution that he thought would work, he was trying to reach out and do some crossover with Republicans to say, hey, let's make this bipartisan. This is a good idea. I think it gives us a structure to work from. And it became an idea that then politics overruled policy. But at the end of the day, the Affordable Care Act is by its nature trying to address, in my mind, and was always designed to address, what is the consequence of uninsured people in America. The uninsured in America cost every consumer who is insured, who does have coverage, money. And so in 2008, 2009, it was estimated that the cost of health insurance in America was increased by 15% for private payers because they were subsidizing the uninsured and underfunding of Medicare and Medicaid. And so if we reduce the number of uninsured, we actually wind up helping the overall cost of healthcare. That was the primary thing. And to create a system where you were having competition, you were having employers, and even individuals look at different options in the market and say, well, that's the right one for me, that's the right one for me. As opposed to a single payer approach, which was, hey, this is what we're offering, take it, that's it, you got to have it.
Right.
And with that became a whole bunch of market reforms and a whole bunch of things that employers had to do. And I think those are the pieces that nobody really figured on. Because, again, you look at the core elements of the ACA, it was benefits. There had to be like an adequate benefit, what we would refer to today as a minimum value, but at least had comprehensive benefits. You had to have it affordable, and it had to be in a way that you were reporting whether or not you were offering coverage, because again, it's the government, they got to make sure they got proof that people did it, and then penalties for not doing it. And what's interesting is at the end of the day, those are the pieces that are still around.
Yeah.
And the pieces that become still a bunch of a problem, and a place that at the core, the ACA has stabilized the market in a lot of ways. And then we've seen things pop up since that have created more instability. But one of the things that we did the day after Obama signed the bill, we sent an email out to all of our agents and staff and said, this is never going away.
Right.
You're going to hear in the market that the Supreme Court's going to do this. I mean, people are going to keep their head in the sand and never worry about this because they don't think it's a problem. It's like the simple reality is this. That bill was written by carriers, hospitals, and pharmaceutical companies. And it's going to get to the Supreme Court. And believe me, there's people on there who have vested interest in making sure those people succeed. So it's never going away. Let's prepare our clients today.
Yeah.
And help them today through that process, which really started our approach to compliance, which has become critical at our success.
I'm really glad that you shared that insight. And as I listen to you, David, I can't help but shake my head and just say, how fucked up is that? I mean, you were right on the money. That's the God's honest truth. Yeah. But it's just, I really feel like to my core, we're being sold down the river by our politicians. And they're not just, when I say we, I mean their family, their friends, their neighbors. Like, it is a huge, huge issue. Yeah. And when you think about what the country was founded on and, all the way on up to the Supreme Court and that's why I think about like $5 trillion. That's a lot of reasons for, that bill that became law to remain law. Yeah. And so how do you overcome that? And so now that we're kind of fast forward, the ACA is still alive and well. And as you say, there are, many components that are contributing to this mess that we're in. Mm-hmm. Is one of those components in your mind, I'm curious to get your opinion, the medical loss ratio?
Yeah, I would say the medical loss ratio provision was always a red herring to me. Because, again, the way that it was defined and the way that it was implemented were not necessarily the same thing. Yeah. The history of it is that Senator Rockefeller from West Virginia was wanting to make sure there was a way to keep the carriers from just charging unreasonable amounts and not being able to protect the market. And so that was, and again, it's one of those things where I say to politicians all the time, your idea sounds great in your head. It sounds great in theory, but like any other policy idea, how does it meet reality? And I always say, like, I think our position as agents, brokers, consultants are better positioned to tell a politician how their idea will meet the road than some policy person who's never dealt with an employer trying to make a decision about how they're buying health insurance, or an individual trying to decide, well, do I want this network or that network? And so the MLR rule on its face is a good idea that, in my opinion, was executed poorly. And the reason is, I'll give you a very simple example today. The way that the medical loss ratio definition was done, it was medical costs had to be at least 80 or 85% in the fully insured market. Right there. Now we've automatically taken half the buyers of healthcare out of the mix.
Right.
So it's only fully insured.
Yep.
And then that gave them money to have profit and to have their overhead and their admin expense, which, if I'm honest, is a reasonable number, but it's played with. And I'll give you the simple example. You go buy Stelara as a drug. Stelara as a drug is retail, not even retail, negotiated price $25,000 a month today. Fortunately, there's biosimilars.
A mere bag of shells.
$300,000.
Wow.
But in that $300,000 cost is about a 50% rebate, where the manufacturer's paying the PBMs, keep our drug on formulary, et cetera, et cetera.
Yep.
So the net cost of that drug is more like, $125,000. Today, the MLR rules allow a carrier who's selling a product, has somebody getting Stelara, they don't have to take that rebate off of the medical loss ratio side. It all 300,000 of that counts towards medical expenses.
Right.
And so the system's been gamed.
Of course.
And so that's the place where I get frustrated, because you see the little gaps, and it goes back to the point I think you made a minute ago, Ray, which is it's a $5 trillion system. And it's not unlike listening to Eisenhower talk about the military-industrial complex.
Yeah.
$5 trillion is a lot of money. It's also a year. So, I mean, and you think about all the people who are making money in that process. Right. And you realize that, and the name of your podcast is fascinating to me because, I've heard the argument, broken healthcare system. It's undoubtedly that it's broken, but the truth of the matter is it works exactly as it was designed.
That is not a concept that is lost on me.
Yeah.
I agree completely. And I think, so you mentioned Rockefeller. So do you know the time frame? How far does that go back, the MLR?
Well, so MLR was actually in the bill. Jay Rockefeller's did not run for re-election to the Senate in 2010.
Okay.
And so that was his last term. But, he had been, obviously, the grandson of John D., had been governor of West Virginia, literally bought the seat, and then was in the Senate for a number of years.
Right.
There's a great story about him, or one of the guys who followed him was another rich dude who decided to be a governor of West Virginia. They spent so much money on advertising, and there's like a little chunk of Maryland that is in the West Virginia TV zones. And so they were broadcasting like everywhere, and people would walk into a voting booth in Maryland and be like, "Hey, where's this Rockefeller guy? I can't. Why can't I
knew
vote
that's
for him?"
where you're going with that. That's
like,
hilarious.
What the hell?
That is too funny.
But it was interesting. Like, that was a guy who was I would say he was very intelligent, very kind of balanced. But when he got on the soapbox, man, you could not get him off of it.
Yeah.
And
yeah. No, and I think on the surface, the MLR sounds perfectly reasonable. Like 80 cents or 85 cents of every dollar should be spent on care, should go to claims. That's the message that people hear. And that's why, I go back in my brain. So I don't know if you know Craig Lack, but he's one of the guys that really taught me a lot in this business.
Yep.
And he always used to say, like, if you're in a room and you're in a room with one of Big Pharma, and the attorney for that Big Pharma company is in the room, That's the smartest guy in the room. He's like, make no mistake about it. He's the smartest guy in the room. And so my mind goes there and I say, well, when this bill was being crafted, you remember all the revisions and going back and forth and like, okay, if you print it out, it's 12 feet high. I go back and I say, there is no doubt in my mind that these guys, these really smart guys and gals, looked at this and said, the MLR is going to be our Trojan horse. Because every time you spend $1 on healthcare, it's more profit for the insurance carrier. And what's the only way for them to make more money? Claims have to go up. So I contend that the MLR is something that, again, on the surface, you can't help but disagree with, the logic behind it. But we have to figure out a better way so that insurance carriers' profits are not tied to billing more. And that's really where I think the rubber meets the road. And I haven't met anyone yet, David, that has a good answer for me on that.
I mean, I think it's going to come down to, and I think you're already starting to see this in the group market, more and more self-funded groups. And because they're self-funded, they've got greater accountability. But the truth of the matter, and I think we heard this in Miami at the large group panel, there's also this reality that a lot of the carriers who are administering self-funded plans do not care. They don't get in the middle of paying as much attention to when they're actually just spending someone else's money than they do their own. And I think that's where some of this pressure is going to come from. But it's going to take some time. It's going to take some real time to continue to find the solutions. But it's like everything else. In healthcare, more than anywhere else, you pull a string and there's a strong likelihood that the entire dress is falling apart. And so you've got to be really thoughtful and careful to make sure as you understand that. It's like right now with the Medicaid expansion in the multiple states, how are those conversations going to happen? Because again, they screw that up. There's actually an impact to the group market. And we already see some of these things impacting the marketplaces and the state exchanges. And that's why you've got to find this constant balancing. But the truth of the matter is, and this has always been my legislative mentality, is you're a member of the House, you're a member of the Senate. Lobbyists walk in, they're representing the carriers, they're representing the hospitals, they're representing, the doctors, the gerontologists, the gastroenterologist, I mean, whoever it is.
Sure.
And they're all arguing about how the system needs to have more attention to them. And I started saying this in kind of an open forum because it's the way I feel. Those guys are arguing over our clients' money. We're actually paying for all these things, and they're up there arguing that they should get a bigger chunk of this, that, or the other. They're money changers. That's all they are.
Right.
They want our money, and they're building a system that's designed to take care of, and frankly, to make people, not necessarily make people sick, but at least tell them they're sick and what they need to do to be sick, as opposed to cure them or help them treat themselves with better lives. And I think that's the place where the real change is going to happen. And again, I may not always agree with the president about a lot of things, but the MAHA stuff is really, I think, important because we know there's a direct relationship between what people eat and their overall health.
Oh, yeah.
And the stuff that's in our food is not always great.
No, 100%. As a matter of fact, I'm glad that you mentioned that because literally this morning I read through the MAHA report. I mean, for anyone that hasn't seen Senator Johnson's committee hearing back before the election, I highly encourage that because you just have an amazing panel of experts that are speaking the truth in I'm going to say in my opinion, but I think it's fact-based.
Yeah.
I'm pretty sure the vast majority of what was discussed there was fact-based. But I do believe that when you go through this report, you can't help but be horrified that we spend far more than any country on the planet. And if you look at, our counterparts who are, modern industrial nations, we rank the lowest in terms of life expectancy. And why is all of that? And I think you can definitely draw a line between our food supply, the crap that we allow, food manufacturers to put into our food supply. And I really applaud the effort to shine a light on this because, as with anything else in our amazing country built on freedom that I love so much, there's corruption everywhere.
Oh, yeah.
Landmines are everywhere. And we just got to get back to a place of common sense. And we got to get our politicians, like what strikes me about what you just shared, David, is we don't have, the people don't have that voice marching into Congress. You could argue and say, well, that's the job of the politicians, but who really is the voice of the people that's the opposing force to this $5 trillion machine? And I think that's really where, again, I don't have a good answer, but maybe we have to start going down the path of prosecuting our politicians for, obviously, in my mind's eye, what's criminal behavior. I mean, we're throwing away, crack dealers who really have no other shot in life but to sell crack on a street. And I mean, we could argue about their sentences being 3 months and them getting out in 2 weeks. That's a whole other, topic for conversation. But let's even take murderers. Well, how would you classify, like, what punitive damage are they doing to the American people by, accepting contributions? And look, they're all playing. Like I've had powerful Washington D.C. guys on the show saying, look, they're not doing anything illegal by the letter of the law. There's a problem with that.
Well, but 3 things you said really strike me. One of them was, I remember when I took the one of the things you have to pass when you become a lawyer is you have to take what's basically an ethics course, an ethics exam, and it's like 100 question or 200 question multiple choice exam. And for every scenario, there's like 4 answers. And the first time I took the practical exam, I failed because for every situation, I chose the most ethical answer.
Right.
Well, that's not the right answer. The right answer is the second most ethical answer because there's always going to be a reason why it's something else. And to me, this is where people who become overly lawyered, overly letter of the law, are missing the intent and how that intent has undermined people's confidence in the government, right, left, or center. And that's the part that bothers people because, I mean, I thought listening to Vani Hari in June was actually really interesting in terms of just have we ever really sat down and read what's in our food? Yeah. And I have I have this candy I like called Haribo, and it's like, and they're originally from Germany, but they will make it in the U.S. The difference between the two is unbelievable.
Night and day.
And it's those little things that we're chasing a profit of 1 cent.
Yeah.
Simplifying a process. And, the comment you made about the corruption, what's interesting is we say that America is not a very corrupt country because you don't really carry cash money around with you to pay off people to leave you alone in case you do something wrong, right? You just don't do that in America.
Right.
But the corruption is, hey, I've got this guy who used to be your chief of staff, now lobbyist, and I know you're the chair of the Senate Help Committee, and he's got a really important thing you want to make sure and some language we want to get stuck in the next bill, and you don't think it's a problem until down the road. And I think those are the things where we really have to say, what's the source of this? But the legislative process is fucked up, man. And it's like people always forget, the House has to pass something, the Senate has to pass something. They're not always the same thing. But what inevitably happens is the House passes something, the Senate passes something, and the House is forced to agree with what the Senate did because there was no way to make a change in it.
Yeah.
The ACA is like that. People forget that the ACA passed the House and it passed the Senate, and then Ted Kennedy died. And so the Democrats went from having 60 votes and enough for cloture to not. And so when it went back to the House, the House had no choice but to sign it because there wasn't enough Democrats going to be left in the Senate to pass it without any changes, which is why we have little weird things between the two. And that's the part where you're like, how lobbyists play a role is the least understood thing in politics.
Yeah, and it's something that we all should understand. Like we talk about how important as a healthcare consultant, as an advisor, how important transparency is. Don't we deserve that as a people, from our elected officials?
Absolutely.
And like when are we going to wake up? And I know this is never going to happen, not in my lifetime for sure, or yours. Where wouldn't it just make sense, instead of burying these obscure little bullshit things into bills, just have a bill be on one thing, just one thing. That's it. You can't take your $1 billion honey project and extort your fellow congressmen and senators to get this passed because you're burying it in the language of this bill, and yet it happens every day. Like, when are we going to wake up and say, that's not good for the American people? It's just not good.
I think what's the great epidemic in America is the lack of appreciation for another perspective and an unwillingness to learn as much as possible before you talk. It is so easy to be against everything, and that's why those kinds of bills don't pass, because somebody's like, well, I don't like your hair color, I don't like your skin, I don't like your mama, I don't like what you did in high school, and whatever it is, people will stand in the way. And it's the reason why, the biggest Christmas bill of all time is the Christmas tree bill of all time is always the defense appropriations bill, because that bill is going to pass. It's always going to pass, but it's got more things dangling off of it than it should, and in part because they can get it through in the dead of night and nobody will read it, and they'll find out in the aftermath what it says.
Right.
Those are the things that if we were able to get a system that was actually more, let's sit down and talk, let's find a middle ground, let's solve these problems. But the media is set up to not encourage that.
Yeah.
I think the messaging that people get in TV news doesn't do that. And I don't think many people take the time to do what I do, which is read the Wall Street Journal and the New York Times.
Right.
Understand that everybody's got a perspective, and you can't be so arrogant as to think that you're right.
All the time, every time.
Yeah. It's like I have children. And an ex-wife. So I've been well aware of the fact that I've been wrong a lot in my life. So now it's just a matter of like, what's the right thing in these conversations?
It's so true. I just think we got to get back to a place. We got to get back to the basics. It's not super complicated, but I agree with you. Even I'm guilty of not just knowing the details about who I'm voting for when it comes down to an election. And it should be easier. Like, you should be able to, and maybe who knows, with AI and ChatGPT, it will be easier for you as a citizen to distill that information prior to pulling a lever or coloring a circle or whatever it is that you're doing out there. But we are, and I've had folks that are from DC on the show, and I tell them, I say, look, whether you're red or blue, you're being lied to. Yeah. You have been, and you continue to be. And it's just, to your point, like if you read the New York Times and you read the Wall Street Journal, you're going to read the same stories but have a completely different perspective. Not always, but often.
So what I've experienced is actually that the body of the story is almost identical.
Yeah.
The only thing that's different between the New York Times and the Wall Street Journal is the headline and the subhead.
Yeah.
It's all about the spin, and it's all about people's short-term attention spans.
Yeah.
It's like, oh, well, dude breaks into building, kills NFL executives.
Right.
Lack of security at building results in the death of 4 people.
Right.
All of a sudden you shifted the blame from the guy who clearly, let's be honest, he drove straight from Nevada.
No drugs in his system.
Yeah. That should be sign 1 to something going on.
Right.
But now you're shifting the blame to the building for having not done what
Yeah.
they should. I mean, and that's the part where, again, people don't have, and again, I'm not saying this absolutely, but people aren't often willing to take the objective, and because some people see that difference and they get mad that one did the other. And it's like, why get mad? I mean,
Yeah.
Why get upset because they said it one way and somebody else said it a different? Read the body of the article.
Right.
They're both saying the same thing. Dude drove from Nevada, clearly has some kind of concussionary issues, decided to take it out on the NFL, killed somebody in the wrong office.
Right.
I mean, like, it's a horrible story no matter how you
spin
say
it. Yeah, for sure.
But you don't say, well, this is why we need gun control rules, because, I mean, hell, there was nobody stopping him at the New York border saying, hey, let me check all your guns.
Right.
And so it's like, this isn't about politics. This is about mental health. And is the guy wrong that clearly concussionary trauma has contributed to where he is? Yes. Is what he did right? Absolutely not.
Not on any planet.
And
No.
so, I mean, that's the part, like, we can't think objectively.
Yeah.
And
Yeah.
it's frustrating because you solve a lot of problems that way.
And listen, you could be sure that as long as news has been around, go back thousands of years, the story has changed to fit whoever the message was being sent by and the intended audience, right? Completely without question. But now we're in a day and age where people are consuming information faster than ever, and it's only getting worse. And so, I think the temptation is to automatically rush to judgment, and we just got to be smarter people. Like we got to slow the music down and say, well, I might hate President Trump or dickhead or whatever you want to call him, right? But don't throw the baby out with the bathwater and say, well, every policy decision his administration supported, I am not in favor of, because that's just not a very smart way to be, right? No. And you could say the same thing if, Kamala would have gotten elected to office. Like her, don't like her, I'm sure there would have been policy decisions that came out of her administration that would have been good policy decisions. Yeah. Some agree with, others disagree with, but we've gotten into a place culturally where I don't feel like it's been quite as bad lately, but it's bad. Like it's on the verge of civil war. I don't think we're there, but I wish we got back to a place where we were more united behind our leader. And I don't think that's possible with Trump. We'll see who comes next and where that all goes. But we're getting off the beaten path a little bit. I'd like to get to, your business, and, the ACA is one thing. ERISA is another thing. They kind of coexist, right? But ERISA is really in the large group space, right? It's
all group space.
All group space. Okay. So educate us, because this is an area of your expertise. So how should an employer, an HR manager, a CFO, a CEO listening, regular person on the street think about ERISA versus ACA?
Well, I would say this. One of the really fascinating points about the ACA is this. It's a big bill. The reason it's a big bill is actually everything in there is in triplicate. There's one part of it that's in the Internal Revenue Code.
Okay.
There's a almost identical duplicate of that inside of the USDOL's section of the U.S. Code.
Yep.
And then a third in what's called the Public Health Service Act, because ERISA only applies to employers who are not churches and are not governmental entities. And so that's why, for example, you see some aspects of it that are purely in the code. Like the employer mandate is a code provision, so it applies to all employers. There are some things within that apply to, within ERISA is all about basically private non-church employers. And then inside of the Public Health Service Act is applying it to all the governmental entities. And so one of my always interesting points about the way that ERISA is structured is COBRA as a law is actually in the statute twice. It's in there in ERISA, and it's in there in the Public Health Service Act, because the Public Health Service Act applies to governmental entities. But ERISA, as a body of law, was passed in 1974 for the explicit purpose, originally, of regulating retirement plans. Because retirement plans, and particularly pension plans at the time, there was more of a patchwork approach in the states. The feds had some, but mainly it was under the SEC, but there was no real body of law to protect it. And so one of the provisions in that was what's called preemption, to basically say this law is going to preempt any state law that conflicts.
Yep.
There was an action by the Hawaii legislature in 1974 to pass what's now called the Hawaii Prepaid Healthcare Act. Out of that was a mandate inside of the state of Hawaii that every employer would have to offer health insurance coverage to their employees. That's the very first employer mandate in America. And when that passed Hawaii, there was suddenly a very big rush to add a second arm within ERISA to include what are called welfare plans, non-retirement plans that included health, disability, dental, vision, life, all the things that we think about. And it was passed exclusively because Hawaii had passed the Prepaid Healthcare Act, and they didn't want other states passing state employer mandates.
When did that pass in Hawaii?
1974.
74 as well.
Yeah.
Right when ERISA got passed.
Right before ERISA got passed.
Wow.
And that was why it got added to ERISA at the end, and a reason why other states couldn't pass employer mandates. And so, and for a long time, ERISA preemption, and particularly as it relates to group health plans, was almost dormant, like nothing happened with it. And then you started seeing Congress, you started seeing the Supreme Court, you started seeing states start to pass laws related to health benefits, and you started seeing ERISA actions. Tony Scalia, who was a member of the Supreme Court for a long time, a guy who, again, I didn't agree with a lot politically with him, but the guy wrote ERISA opinions that were like just poetry. And every year, even last year, there's an ERISA case before the Supreme Court. And the one last year was ultimately the decision that said Oklahoma's PBM law was going to get preempted by ERISA. And so you see this body of law that's all about setting the rules about who you offer coverage to, what that coverage should look like, how you communicate to your employees what that coverage is. People are like, what? ERISA seems very complicated. It's not. You have plans, and within a plan, you've got to have really 4 things. Who's eligible to enroll in the plan? Are there any beneficiaries allowed under that plan? What kind of benefits does someone get from that plan? And then how is it paid for? So, easy example, dental. Who's eligible to enroll in a group dental plan? Well, our employees who work 30 more hours a week, 35 more hours a week, 40 more hours a week. Who's the eligible dependents? The spouses, the children, the grandmama, all those things. You can define those things within ERISA. What are those benefits? You get a cleaning, we're going to pay 90% of the usual and customary, and you're not going to pay anything for cleanings, but you are for cavities and the like. And then how are you going to pay for it? Well, we're going to collect part of it from employees. The employer is going to pay part of it. Very basic.
Spells it out.
Right. And those rules, interestingly, I don't think we're taught a lot about. But at the core of it, it makes sense.
Yeah.
Like, that's really what it is. And then from there, some things got passed, like federal benefit mandates. Like there's the drive-by delivery bill that was passed during Clinton, which was you couldn't make a woman go home after having a vaginal birth quicker than 48 hours after birth. Cesarean, 72 hours. So that became the Women's Healthcare Rights Act. You've seen breast cancer as a federal mandate. But you don't have what you have in a lot of states, which is a whole bunch of other mandates. And then from there, it became all the pieces that we start to see. HIPAA, we all think about HIPAA privacy and security. HIPAA is under ERISA. But HIPAA's biggest things that affect healthcare are it prohibits discrimination on the basis of health status. So you can't take an employee who's sick and fire them because that's a violation of HIPAA non-discrimination.
Right.
HIPAA also added for the first time, codified rules about special enrollment period events. So, you got somebody who gets married, they can add their spouse. They have a kid, the kid turns 26. I mean, all those things are all
Qualified
within ERISA.
events, right?
And what's happened is ERISA's become this amoeba. And I'll tell you a funny story from the lawyer side. In 2008, there's a subgroup under the American Bar Association called the Joint Committee on Employee Benefits. Their meeting was in New Orleans that year. There were probably 300 people there. Of the 300 people who were there, 295 of them did nothing but retirement plans. There was next to no one there who talked about health plans and everything else. 2008. Guess what? 2 years later, totally different demographic because now all of a sudden people had to go there because they were going to have all this business. But ERISA has become the foundation of trying to create a better federal regulatory structure, but we still have the dichotomy. We still have states have their roles, the feds have their roles, and those things conflict from time to time. But we just passed a law in North Carolina on PBM regulation that doesn't apply to self-funded employers because ERISA preemption says if you're self-funded, you're exempt from state regulation. You're exempt from state benefit mandates. And so each of these things start becoming places that you build upon. I'm speaking to the NAIC in a couple of weeks about level funded, and they're like, what's one of the reasons why employers are buying level funded plans? Like they're escaping ACA small group mandates and they're escaping state regulation. So, yeah, it makes sense for employers.
So when you speak about that, give us an example of what an employer is escaping when migrating to ERISA from ACA. What's like, I don't know if there's, public enemy number one. But
I'd say this, having done a lot of work at the state legislative level in North Carolina, I used to always laugh about the fact that every year there'd be a benefit mandate. And sometimes that somebody would show up famous to do it. Sharon Stone was one of the first people to go out state by state to push the mandate that certain autism benefits be covered under health plans. And a lot of states have passed them. They don't apply to self-funded plans.
The Sharon Stone?
The Sharon Stone.
Was she sitting on stage in a short dress and was she crossing in on crossing
I was never
legs?
actually there when she was in Raleigh, but I'm sure she was not afraid to do a little flash to get there. But again, very smart strategy because you got somebody that, if you're a legislator, you sure as hell want your arm around her.
Right.
I mean, and so, but I'll give you a really interesting.
And that, by the way, shout out to Sharon Stone. That's lending yourself to a worthy cause. Right. Like, really, that's cool.
Absolutely. And listen, I don't disagree with the issue. I mean, if you look at the very foundation of it, autism's a real thing in America.
Yeah.
And if you're a carrier in particular, the reason why autism scares you is because you don't know what the reasonable bounds of the spend are. But you think about where we are now versus 10 years ago.
Yep.
I mean, a lot more open and acknowledgement and a lot better science around it now. But I'll give you another example. Indiana passed a law that said that people who live in Indiana who are on health insurance, who are on health plans, would have to be able to get IVF, in vitro fertilization benefits. All right. Well, you're an employer in Indiana.
That's expensive.
It can be expensive, but again, I would tell you, like the consultant part of me says, IVF is a benefit that you do a good job designing and implementing is actually cheap. And I'll tell you why in a second. But if you're an employer in North Carolina and you have an employee who lives in Indiana and you're on a group plan, the Indiana mandate doesn't apply to you because your group plan's based in North Carolina. You're a self-funded employer in Indiana, then the mandate doesn't apply. But here's where the problem is. All the TV stations are, and this week the legislature passed a bill saying that in Indiana, people will be guaranteed the right to access to IVF. So you have an employee who works for your company in Indiana, but you're self-funded. It's like, hey, when can I take advantage of this?
Right.
That rule doesn't apply to us.
Doesn't apply. Yeah.
And that creates this odd sort of friction as well But this is the place where, I got people complaining about too many mandates in the state. I think there are a lot of state mandates. A lot of them are things that are already covered. So at one level, we're mandating something to be covered that most plans are already covering because they know they need to, just because that's the only way people are going to buy it. Like, who's going to buy a car that doesn't have headlamps?
Right.
Right. But do we need a state mandate saying that every car has to have headlights?
God, I hope not.
Don't put it beyond people.
Might not pass inspection.
Yeah.
Right. Yeah.
But you start to see, like, ERISA is kind of this, at one level, a very firm castle, still to some degree built on sand.
Yeah.
That there's always that underlying fight. And there's people who hate ERISA preemption, truly hate it. Because, again, you want to regulate PBMs and you're having a hard time getting it through Congress, or we'll go to the state. When you've automatically excluded 50% of employers.
Right.
I'd say 50% of the people covered by employers from whatever mandate you just passed, because it doesn't apply to them.
Doesn't apply. Interesting. Episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. So give me an idea of what type of legislation got passed regarding a PBM. Good for the consumer or bad for the consumer?
I would say this. In my experience, very little regulation of PBMs have necessarily been good for consumers.
Yeah.
And mainly because by the time they get there, they've been watered down.
Right.
If we were to pass, in my mind, real legislation on this issue, we would have to simply require absolute, pristine, complete, and total transparency.
Right.
And the only way you're getting that is by putting hundreds of millions of dollars of fines around it.
Yeah.
Because, and it's funny, we just did this with a prospect the other day. We asked the PBM for a list of all the drugs. We're in a complete drug run because we wanted to really do the analysis. Are they spending the right money? They happen to be on a spread pricing plan, and we wanted to, see all those. Immediately, they want us to sign what's called a data use agreement. So it's restricting our ability to give all the detail to any other vendor because they don't want their competitors to know what their discounts are.
Right.
Which, let's be honest, bullshit. They know what their discounts are. But they don't want us to give that to them. Okay, great. So you strip out some pieces. But the thing that we asked for that really made the PBM mad was we know what you're going to report as what was paid for this claim. We also want to know what was paid to the pharmacist for this claim. And people are like, well, isn't that the same thing? The honest answer to that question is no, it is not.
No.
And it's not even the difference between cost and spread pricing, because, oftentimes the net cost of that claim, let's say the drug costs $27.
Yep.
And there's a $5 fill fee.
Yep.
So they were $32, right?
Yep.
And so you're thinking they're getting paid $32, but they might not be. They might have been paid $32, but $3 of it was withheld because they were in the middle of auditing that, and the pharmacy's got to figure out all these pieces. And PBM legislation is a great example of something where you've got the two parties on this are community pharmacists and PBMs. Mm-hmm. And it's not even all PBMs. It's like the big 3 or 5 who are making the vast majority of the money, who, by the way, are already well represented in the legislature because Blue Cross has got a lobbyist, or Anthem in this state, United, Cigna, Aetna. All those guys have already got people there. So now they're just doing something slightly different with the PBM. But I sat in meetings where, somebody's like, well, there's no way the legislature in North Carolina is ever going to pass this bill because, this is a pro-free market Republican majority. It's never going to happen.
Yep.
And I'm like, put my hand up. I'm like, hey, guys, I'm just going to raise the following. The states that have passed the most draconian, firm PBM legislation in America are Texas, Florida, Arkansas, and Oklahoma.
All bright blue states.
Oh, yeah. And they're like, I was like, this isn't like one of those political alignment things because
Right.
you're arguing this is about free market and they're worried about the little guys getting stomped on by you. And if you think that's something that you're going to align all Republicans on because you're big business and you should be protected, those 4 states should be a clarion call to you about how difficult this is.
Right.
You look at Democratic states, they haven't passed laws as strict as those 4 states have.
Yeah.
I mean, you got Ken Paxton in Texas saying, hey, Texas's PBM legislation, it applies to self-funded employers, and we're going to fight anybody who argues that it doesn't, and we're going to fight preemption on it.
Wow.
And you're like, damn, dude, I would not have expected those words out of your mouth. And,
Yeah.
And so this is a good example of where ERISA is creating this almost dichotomy.
Yeah.
And it becomes a problem because if you're a pharmacist, you're a community pharmacist somewhere in America, your life sucks because all the things you've got to do to stay ahead, just to keep the money you got in your bank account.
Right. Yeah. They're making it really difficult.
They really
well,
are.
listen, when the big 3 control 90% of the drug marketplace, AKA the cartel,
Yeah.
right? Let's just call it what it is. That's kind of the world that we're living in right now. But the mind blower for me is, how many self-funded employers are out there, large corporations, that are still doing business with those fucking guys.
A lot.
It's like, and they claim that, well, we get rebates. You get rebates. Come on, man.
It's the game. I mean, David Mordo and I wrote this PBM class for NABIP, and you start digging into it. And we called a friend of ours who works for a PBM and said, hey, what are all the revenue streams that PBMs make off of, their role in the system?
Over 30.
And it was like 30 things, and you're like, how the hell does this happen? But it comes back down to this. You know why PBMs have the power they do? They pay fast.
Yeah.
And I made this comment to somebody yesterday. It's like, look at your credit card. Credit card or debit card, the reason why those are so prevalent is very simple. If I run a credit card transaction, do you know what no one has that can be stolen? Money.
Mm-hmm.
And so there's a reason why countries like India have gone to completely cashless societies, because it's eliminated a whole bunch of related crime. And what have merchants been willing to do for years? Eat that 3%.
Right.
Because it's convenient.
Yeah.
And what's happened with PBMs is the exact same thing. The average time for the payment of a medical claim in America, if you take like all of them,
Yeah.
is about 30 days.
Okay. That's
And-
better than I would have expected.
Right, but you have to bifurcate that. So
Right.
like if it's a primary care visit, you're going to see a specialist, you get exam, you're getting blood tests done, all those things,
Right.
25 to 30 days.
Right.
Claiming more than $1,000, 60 days.
$200,000 surgery.
$200,000 surgery, it could be 6 months.
Right.
And not 6 months because the carrier's got it and they're holding it.
Yeah.
It's because it might take the provider 3 months to bill it.
Right.
I mean, I had one of these happen with a client who the guy had a stroke and then sepsis, and that was the 5th day of January. And in the middle of March and the 1st of April, I'm like, where's this claim due? Because this plan renews 7/1, and we're not going to pay for this guy on the other side of the renewal when the stop loss deductible is going to reset. So I'm like, I'm calling the TPA like, where's this claim? Pay this claim. Stop fucking around, because we're not going to pay another deductible on this guy next year. Bingo, bango, that's it.
Right.
And so you got that. The average period of time between you getting a prescription filled and that pharmacy getting paid in America, 7 days. And so paying people fast,
Yeah.
it
Greases the wheels.
It really does.
Well, it's cash flow, right? It's cash flow, and that's huge. I'm going to run this by you. So the now CEO of American Express, Steve Squeary, went to my high school. And so I know the guy like casually. Very, very wonderful guy. And I thought to myself, in the world that we're in, when we're encouraging employers, for the most part, to take a look at self-funding, level funding, controlling the supply chain of healthcare, the biggest sticking point is the payment mechanism. What if American Express was a fast payer and just was accepted as at point of sale, no questions asked? Why do we need a Cigna network, a United network, an Aetna network? Pick a flavor. If you could go to a freestanding surgical clinic or a hospital for that matter, pick a flavor. We're in New York City, NYU, Columbia, and present your American Express card. That doubles as your health insurance ID card. Payment is accepted, and we know if I have a health insurance ID card, I don't know about North Carolina, but I'm telling you, in New York City, it might take me weeks to get an appointment for something that could potentially be a life-threatening illness. But if I say I'm cash pay, whoa, the calendar magically opens up. Come on in, Mr. Smith. Would you like an espresso? There's a lot to be said about cash pay and negotiated payments, but what do you think of that?
There's a couple of vendors out there doing it today. And so what I say to employers nowadays is you have a range of options.
Yeah.
You're being told these are the only things you can do, but you have a range of options on how your medical claims are paid. You have a range of options on how your prescription drug claims are paid. You have a range of options on the networks and how you would access doctors and hospitals. And you have a range of options on how you finance and ultimately protect yourself in that mechanism.
Yeah.
And your willingness to do that, in my mind, has come down to a very simple calculation of what's your risk tolerance, what's your risk assessment, what do you look like as a group, what are you willing to do, and what are the limits of that in terms of how far out on a plank you're willing to get to. People have talked about RBP, and RBP as a saving grace, reference-based pricing is a saving grace, which is, hey, Mr. Physician, Madam Doctor, hospital administrator, I'm not going to have you tell me what I'm going to pay you. I'm only going to pay you 130 or 170% of the Medicare reimbursement schedule. Again, this is America. My experience is that in those scenarios, the provider of the service has the God-given right to tell you to fuck off.
Right, sure.
And it's a reason why RBP is suffering, because what you're doing is saying, hey, this is all I'm paying you.
Right.
And so what I've seen with the cash pay models is literally that approach. My ID card is a debit card.
Yep.
And I go in, it's like, I'm cash pay. And they're like, all right, great. It's $80. Swipe, done.
Right.
It's, $400,000, but if you're cash pay, it's $150. All right, we'll make payment tonight.
Right.
And that approach is going to be effective as long as you've got the right grease in the system, as long as you can make it easy. Because the other thing, Ray, that I've discovered is, and I know this is not shocking to you, but it's shocking how many people, when I say this to a vendor, I say this to somebody else who's in the business, who's trying to sell me what they're doing, this is very basic. We're smarter than the average healthcare consumer. My mom, who's 83, if you told her she had to go in and every time she went to see her doctor, hey, tell them you're cash pay, she'd be like, what the hell are you talking about?
Right.
I'm just going to show my ID card and they're going to run it through insurance. I don't have to worry about it.
Yep.
And so we make it also very complicated on the back end.
Yeah.
And that's frustrating too. I mean, it's a reason why our role is so important. But like I had this conversation yesterday with somebody, like I almost believe that you've got to build a team of 10 or 20, 30 concierge who you've really given them the juice, man. They believe wholeheartedly that their entire job is to make people's lives easier.
Yeah.
and that they're not going to complain about the one in 100 that are a pain in the ass, and just realize you're here to help them. You're here to call the doctor and say, hey, this is what we're doing to help. I've listened to Nurse Deb, for example, talk about how she feels about it. But I also feel like her style is way too over the top for people.
Yeah.
You've got to be more of the warm blanket and not the fuck you, do it my way, and for it to really work well.
100%. I couldn't agree with you more. I think that the greatest thing, one of the reasons that I do this show is because it gives me a megaphone and it gives me a voice, and hopefully I could change more than a few lives of when people tune in and they actually listen. But one of the things that really, my belief is that we as a society need to push back when a provider asks us for our insurance ID card when we call them for health care. Your insurance ID card has nothing to do with health care. No. Do they deserve the obligation of payment? 100%. You need to be responsible and pay your bill. But the second thing that you need to do after you push back on that insurance ID card is ask what the fucking price is, right? Because we have this magic ID card in our wallet that, if I go to NYU for, a CAT scan, they're going to bill $8,000 for that, exam, for that major diagnostic test. And if I go to a freestanding radiological clinic like Zwanger and Passeri here in New York, shout out to them, that same exact test might be $800, 1/10 the cost. And so I think as a society, we do need to push back on the question when asked of what insurance do you have? And the second thing that we really have to start paying attention to is what is the cost of this? And the other thing is really, not to get on a soapbox, but this could be life-saving advice, because if you do ask for a cash pay price, and you learn that your portion of the expense going through your insurance would actually cost you more than the cash pay price, if you can get on that calendar sooner, well, sometimes if we're talking about, a malevolent disease like cancer, days matter, minutes matter, hours matter. It could save your life.
Absolutely.
We got to start paying attention to this stuff. So tell me, when you sit down with a client, or just the overarching mission of your firm, remind us of the name of your firm.
eBen Benefits.
eBen Benefits. I'm getting the sense that your approach is very similar to mine, and that you're not ramming things down your prospective clients' throats. What is your approach? Let's say, and I understand that there's going to be a variation depending upon the size of the group. But let's say for argument's sake, it is a good candidate for self-funding. It's a 200, employees on plan type of a group. What's your approach, and how should a business leader, someone that is tasked with kind of managing this expense, think about it?
Well, I think, I always say to people, we still believe strongly some of the foundations of what our business, our profession does, which is we still need to have somebody involved as the quarterback. We still need to have very good customer service. And what we're finding is the larger the agency, the less important that piece is. And so those are pieces that I think have to be important. Relationships matter, and the ability to trust somebody is good. The thing that I've noticed in the market is we have, a lot of different people in the business who have very differing levels of knowledge and skills in terms of being able to sell benefits and talk about benefits. And for me, it's come down to that conversation about how you finance healthcare that is, in part, very much an exploration of what's your risk tolerance? What are you willing to do? Are you scared of any risk? Because that's not only fully insured versus self-funded, or fully insured level funded versus self-funded, but it's also, if you're going to be self-funded, what's your spec deductible? What's your specific stop loss deductible? And does it need to be low? Can it be higher? Are you willing to pay less and take more risk? Or do you want to pay as much as possible and take as little risk as possible and find those balance areas? And then it becomes, what do you want your plan to look like? How do you want it to really operate? I I mean, it's the point that you said about like the imaging centers. Like, how do you start building systems that actually make it easy for consumers to know if I go here, it's $7,000. If I go here, it's $700. And by the way, you have a financial incentive to go here instead of there, because we're not only going to say you're going to pay less than what your out-of-pocket max is or what your deductible is, we might actually eat some part of that because you chose that place. But then you run into the hardcore infrastructure issues. How many TPAs are set up to do that? How many can actually administer in the right way? I've been talking to Garner Health about their approach, which is very much like looking at measuring doctors on their outcomes, and then not doing what everybody else does, which is tell the doctors what questions are on the test. Because you know what? They're doctors. They only got through college and medical school and where they are today because they are really good at passing exams.
Rote memorization.
Yeah.
Sure.
And so you tell me I've got to do these 10 things to be considered top, I'll do all 10 of those things. If you don't know what those criteria are, and I'm simply measuring you based on how often does somebody have to have a revision to back surgery when that's your primary practice. How many people have had complications as a result of that? What's your net cost on those? How often do you start with PT or other approaches? And so building a system that says, hey, and it's, the model that they talk about is like, it's the people that matter, not the building. So you got 15 people in that practice who are on cardiology. These 3 are the good 3. The other 12 are okay.
Yeah. But
these are the 3 that you want to go to. The Cancer Study Group did a great study a few years ago about if you have breast cancer in Philadelphia, does the likelihood of you having a successful outcome from that course of treatment can be blocks different in terms of what practice you go to have that treatment.
Sure.
And so this is the place where the really interesting thing is going to be how big data starts to play into this. The surest plan designs that United has done are actually brilliant because they're really doing applied consumer-driven plans for the first time. My only concern is that how much are they saying, this is the person we're going to charge you a $10 copay to go to versus this person we're going to charge you a $60 copay to go to. Is this person really not only cheaper if you're United, but are they also a better provider? And so, what weight do they put in that scoring?
Yeah.
And each of those things become ways that you start to figure out what people want to do. The other thing is very few people want to do anything first year. They just want to have confidence in somebody who's going to look at their stuff, give them real insight.
Right.
And, I always tell people I'm from the mountains of North Carolina. I don't trust people who live on flat land to begin with. And I don't trust anybody who gives me the reports that they think I ought to show somebody else.
Right.
Because I'm assuming they're only telling me what's good, not what's bad.
Right.
And so this is a place where I think a lot of agencies are not set up to do the hardcore data analytics, digging into it, and then asking questions.
Yeah.
I've got this great guy who works for me named Wayne Ellis, who just really, really smart, a guy that you would not in a million years think, oh, this is the guy that I would do this to. Hired him as account manager. He got in to start using Excel and just fell in love with it. And now is the guy who, we have a self-funded client, they have a weird claim, and he's got questions about it. He'll call the account manager at the carrier or the TPA, be like, what's going on with this claim? Why it was not paid properly? It should have been this, 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 and this. And they'll call me, and it's like, why is this guy calling me like every day? And it's like, because you need to call him back and give him the answers to his questions.
You got to get it right.
Yeah.
Yeah.
And if there's an answer to it that's good, no big deal. If there's an answer to this question that you've fucked up, he is not going to stop calling you until you fix it.
Right.
So fix it.
Yeah. No, that's huge. And, how many of our counterparts don't have that type of oversight on claims? And to your point, it's really tough to find good TPAs in our experience. I could really kind of count them on one hand. And ultimately, you never know until you personally place a client and have experience with them. And then you really have an appreciation for, okay, are they walking the walk that, they talked? And most of them, I hate to say it, are not. I want to get back to something that you touched on, though, in terms of risk. If we're in the risk business, that's what insurance is after all, right? So I've gone on record as saying that a properly designed level funded plan is inherently less risky than a fully insured plan. Agree or disagree with that?
I agree with that, but I think the devil's in the details. And so part of the starting point of your question is important. You talk to somebody who's a commercial insurance agent or broker.
Yeah.
A lot of those folks went to school. They went through risk management programs. They worked in a carrier. Now they're out working for some big, small, whatever agency, and they're all very specialized. I live in a high-rise condominium building in downtown Durham, North Carolina. Our agent on our building is somebody from Hub in New Jersey.
Yep.
Because, again, high-rise condominium buildings, somewhat of a specialty risk, but that's a guy who you know has done one thing consistently, which is he reads every insurance contract that comes across his desk because he's got to make sure that nothing is off. In our business, and I do this all the time when I'm teaching level funded, self-funded, or whatever. We stand in a room. I did this in Georgia 2 months ago. And I stood in front of the room and I was like, how many people in here have read an entire insurance contract in the last 3 years? And from the stage, Ray,
Yeah.
I can almost tell you who those
Right.
5 people are
Yeah.
before they raise their hands.
Right.
Because on our side of the business, on the EB side, we're not taught
Yeah.
about risk management.
Yep.
We're not taught to think about risk tolerance.
Yep.
I mean, the word risk is, in the name of the agency that bought us, but on the EB side,
Yep.
it's and part of the reason for that is very straightforward. If you're buying fully insured health insurance,
Yep.
you know that product has been reviewed by 18 people in the Department of Financial Services in Albany.
Right.
And you know that there's no way they would have ever signed off on that
Right.
without having done a bunch of checks.
Yep.
And so you know that if you got a claim that Anthem's going to deny, you also got the ability to pick up the phone, call somebody at Anthem, and be like, hey, what the hell is this? This isn't right, blah, 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 blah.
Right.
Level funded is really becoming a little more of that advanced level of knowledge. And one of the things that I'm running to is very few agents
Yep.
are really aware of the fact that there are different things they have to do. And the level funded class I teach, I have a great kind of opening slide, and it's an optical illusion. It's a guy that if you look at him, he could either be looking at you,
Right.
or he's looking to his left.
Picasso.
And the question is, I was like, this is the perfect analogy because we sell level funded, and I hear this word all the time,
Yeah.
that it's just like being fully insured.
No.
And the other side of it is like, but the reality is that level funded is self-funded with complications.
Yeah.
And so, and it's for me, it's like contract terms.
Yes.
You ask 90% of agents who sell level funded what a contract term is, they don't know the answer.
That's scary.
And I mean, I had this situation happen with a TPA that asked me to help them a couple of years ago start a level funded plan.
Right.
And so I went through, told them all the things, and I was like, never sell a stop loss policy that's not at least 1218 with terminal liability, not TLO, true terminal liability. So at 18 months, you're doing the claims reconciliation, you're reserving for IBNR, you're giving back a share of the claims or all the claims reserved back, or a 1227 without terminal liability, because that's the only way you really can feel confident that you get beyond the likelihood of having any claims come in after the end of the contract.
Explain terminal liability.
So terminal liability is I'm truly limiting your liability for any claims that come in to be paid after this point in time. So it almost becomes like a 12 infinity kind of contract, but it's basically saying, because again, at the core level funded, you got 3 pieces in that rate.
Right.
It's not a premium because there's not an insurance contract.
Right.
But that amount that you're paying every month, about a third of it is stop loss.
Yep.
About a third of it is admin, maybe less, but not often.
Yep.
And the remainder is what you're putting aside in the claims reserve.
Yep.
And so when you got a 12-18 with terminal liability, you're going to say, hey, if we get to the end of the 18th month and you have money left over in your claims account, then at that point in time, we're going to project what we think is left. What's out there that has been paid, we're going to do an incurred calculation. And let's say you got $10,000 and we think there's a couple $1,000s in claims out there, then we've got $8,000 to distribute back to you. But we're assuming liability for all those claims that come in from here on out. And if it's more than $2,000, then we're where we are.
Right.
We're stuck with it.
Right.
Which is different than terminal liability option, which is I'm going to exercise an extension of my stop loss contract by 3 or 6 months.
So here's an interesting question: is the liability assumed by the stop loss carrier, or is that the employer sponsors liability?
So under ERISA, if you are self-funded, the employer or the plan sponsor is assuming complete responsibility for all claims. But they're buying stop loss to limit their liability either on a specific basis, one person up to a certain number, or in aggregate, everybody covered below that spec deductible. And so the short answer to your question is it depends. Ultimately, the employer has liability. The stop loss should be designed in a way to protect them. But this is where there's the gap of knowledge. Tell me a 5-life group that's going to buy a level funded plan that really understands what the hell they're buying.
Right.
They don't exist.
Yeah.
It's just another way they're buying health insurance in their minds.
Right.
And the more we dig into these problems, I think it's going to create other problems down the road. Like I'm a believer that most legislation in America happens because the cousin, best friend, or relative of a member of Congress or a senator runs into a problem, and all of a sudden now we need legislation to keep that person from people like him from ever being heard before.
Right.
And level funded, if we're not careful, is going to bite us like that.
Interesting.
But this TPA that I was helping, I said never do less than 1218 terminal liability, 1227. You're going to make sure that people don't have claims that come in that are uncovered.
Right.
So they called me a couple weeks ago and they said, hey, we've got a guy, one of our sales reps was really trying hard to sell this piece of business. And he, did it, got this group sold. They were paying in over the course of the year $250,000 into their claims reserve. Within 5 months, that had $1 million in claims. And so
it's upside down.
But he had pressed hard on the fixed cost.
Right.
And so the group bought a 12-12 contract with a terminal liability option that specifically said you can only exercise the terminal liability option if you are moving this group back to being fully insured. Well, the group was over 50. In North Carolina, that's a small group. I know in New York it's 100.
100, yeah.
But they were over 50.
Yep.
So they couldn't go to the fully insured market because they were dogs. There's no way anybody was going to write them.
Right.
And so they were able to convince Cigna to replace the TPA as the new carrier for their renewal on their level funded plan. They did a 12-12 contract, and they had no run-out protection on their stop loss. They had no run-in protection on the Cigna contract. And so this group now, and what's interesting is this: the TPA sales rep was calling the folks at the TPA saying, no, we got to take all the liability. I mean, this is just the way it works. And we're like, no, dude, that's not at all the way it works. It's the group's liability. You bent over backwards to sell a case to one of your biggest brokers, and it's going to bite you. And when it bites you, you're going to lose that relationship, and that broker is going to have a ton of liability. And now you've created, the opening fire of a storm,
right,
that is going to become a major, major problem. And it's because people don't understand that it is so fundamentally different.
Right. Yeah. But had they gone back and if they had the proper consigliere, they had the proper counsel, and they mirrored, so they're coming from a fully insured plan, they mirror the SBC for that fully insured plan, the SBD for that fully insured plan, and they have the proper stop loss in place, then if lightning strikes and you have 3 heart, transplant recipients on that group, no matter how small it is, they're covered. But the devil is in the details. And and I always tell my clients, and personally, if I'm going to read anything, I'm reading what's not covered.
Yeah.
I'm comparing 2 documents. Where are you coming from? What are we proposing? How do they line up? And if they don't line up precisely, how don't they line up precisely? And that's what you have to focus on. Because my biggest concern about being a consultant is missing a detail that exposes my client. I don't ever want to be that guy. I want to know with 100% certainty that the plan that I'm putting them on is at least as risky as the plan that they are coming from, but no more risky.
Yeah.
And I think that's the job of any good consultant, but it's very easy, I think, particularly in busy season with a lot of stuff going on, to miss stuff like that. And that's the kind of shit that keeps me up at night. I'm like, I don't want to be that guy.
Yeah, we've had multiple situations in the last year where the level funded contract's got a 30-day notice on it. And so the group doesn't make a decision until, 20 days prior to renewal.
Right.
And then somebody's got an ID card. It's still active. I mean, all these things that happen.
Sure.
That in a level funded world don't work the way they work in a fully insured world. And now all of a sudden groups are getting another month of premium that they weren't anticipating.
Right.
All these little gotchas. Like nobody pays attention to minimum premium or minimum ag attachment points.
Yep.
And you got a group that was at 30 and they dropped to 20.
Yep.
And they had monthly accommodation and all these other things in their level funded plan. And now they're being told, well, you didn't hit minimum. And so we reimbursed $100,000 for the claims more than we should have. You owe us $100,000.
Right.
Those are hardcore realities.
Yeah, that stuff happens every day.
And so for me, it's the simple things like, did we make sure there's not a minimum ag attachment on this?
Right.
What are our rules to get out mid-year if we have to?
Right.
How do we anticipate part of these problems? Because there's business realities.
Right.
And I think that's the place you should get bit.
Yeah, and our clients don't know this business, right? They just don't know it. They know their business, and they rely on professionals like us to know our business so that we can properly advise them. And the flip side though is we're talking about saving meaningful bottom line dollars for these organizations that are now spending, on average, you have 100-person group, you're spending over $1 million likely. Could you spend $500,000 or $600,000? You actually can.
Yeah.
But it's not going to happen without some risk. You taking on some risk and, just kind of diving in, getting a better understanding of what's possible. And to your point, I'm a big fan of getting the boots on the ground, informed and engaged. And I know there are certain people in our industry that are just like, you can't educate people and make them better consumers of healthcare. I disagree. I think you can, during open enrollment meetings, through communication, let employees know that this is an unsustainable expense, that if we keep on this path, it's going to go away sooner or later. And what the organization has decided to do instead is migrate to a plan that incentivizes employees to make the best decision they can. And when they do that, their health expense is virtually free.
Yeah.
And so, you then get people moving away from that big hospital system, charging 10x for a major diagnostic exam, that they would, making a choice, going down the street, or having a TPA that advises them properly. And so ultimately, I think it really boils down to folks like us doing our job, laying it out for our clients and leading them, hopefully, to a better understanding of what their options are. And then it's up to them to pull the trigger.
Yep, absolutely.
Right.
I mean, we have to create some level of accountability and create the right financial incentives, and then ultimately you got to watch the claims. You got to watch the claims and know what's going on.
Yeah. No, and the other thing that we really didn't touch on, and we're kind of out of time today, but it just in terms of a CFO, a CEO, HR leader, understanding that now after the passage of the CAA, their asses are on the line. They have a fiduciary obligation to spend plan dollars wisely in the same way that they do with their retirement plans. And now, the litigation is starting to come. And so I'm sure that's part of your conversation with these folks.
It is. And I tell you what's interesting about that is and I say to my clients all the time, shop me. Because I know what I cost. I know what I do for it. Like we totally changed our model by doing the risk management approach to benefits, by actually making a compliance promise to our clients saying, hey, we're going to do the work for you and we'll indemnify you for our work. And then to say we're going to be completely transparent what we're getting paid. We've moved, I think, all of our large group clients, so 100 plus, to a consulting fee that we're billing and collecting. We're not letting a TPA doing it, any of those things.
Mm-hmm.
And I've had people, how can you afford to give a compliance promise? How can you, why are you okay sending your clients bills? It's like, the compliance promise is easy. The business risk greatly exceeds the legal risk.
Yeah.
Because if I don't help a client do something, I can't get sued, but they're going to fire me, and that's more expensive.
Right.
On the consulting fee side, I would much rather send a client a bill every month for them to pay every month.
Yeah.
Because in my mind, when they get that bill, the question is going to be, are they worth it? And I like that accountability. I like that accountability throughout the year.
Right.
Because I never worry about it. I think that what CFOs, business owners, everybody else has to do is stop and think, what's this person's motivation for wanting this product?
Right.
I start every prospect meeting with hey, we want to listen, so tell me what you're thinking. Tell me what you want your benefits to look like in 5 years. Tell me what you hate about your benefits today.
Yeah.
Tell me about your business plans. Because in that environment, what you're doing is you're listening. You're stopping the sales process, and you're becoming a consultant, and you're bringing value in that.
Yeah.
It's like, I'm not here to save you money, because saving money is a false promise.
Mm-hmm.
But I can more than likely help you stabilize what your cost changes look like every year, because this is where we're going to start digging into. You want more people getting their physicals. Let's figure out a way to make that happen.
Mm-hmm.
You got people who are type 2 diabetics. Let's get them a very active disease management program, because they're going to get the greatest value long term from that. Each of these elements become an essential part of listening, knowing that every client is different. And yet I run into competitors who we've got this special program that'll do this. And my answer is like, well, what are they making on that? Like, literally, what kind of back end revenue are they making? Why are they pushing that versus literally saying, there are 8 things like this in the market. Here's the ones that I think are the best fit for you, but let's talk to them.
Yeah.
And that's the place where I would say the big houses have built a model like, hey, we're the best. We know what we're doing. And the truth of the matter is, every one of them are conflicted to the hilt on every solution that they're bringing to the table, because they've all got back end revenue.
Yeah.
So
no, it's true. And so what David's referring to, for anybody that might not be familiar, the typical model is the broker is paid through the carriers, right? It's through commission, and there's what's disclosed, and then there's what's not disclosed, and there's a lot of money flowing back and forth. And so I admire that. I admire a model where you're you're really kind of putting your money where your mouth is and being transparent and saying, hey, you're going to get an invoice from us on a monthly basis. And, it's hiding in plain sight. There it is. Yep. And are we worth it or are we not? And I think that is admirable because you're basically putting it out there on display. And it's something that your client, they probably don't appreciate it as much as they should. But I think big picture, it's just honest at the end of the day. Yeah. I admire that.
Well, and to bring it full circle, it's I now know what I'm worth.
Yeah.
And it's like, this is what I do. This is what I cost. And if you want to do business with me, great.
Right.
And if you don't, I understand that. Best wishes to you.
Right.
But the difference is I'm going to be the guy who, you got a problem, I'm going to solve it for you.
Right.
I got a client email me earlier today about a disability question.
Yeah.
Here's the answer. Bang.
Right.
And I'm not going to sit there and incrementally bill you.
Right.
But I'm the guy that when you need me, you're going to need me. And as we're looking at claims, all of those become the people who are really invested in their clients.
Right.
And I've said to a bunch of people, and I think this is where my client growth has come from, is like, after 6 months, you'll realize when I said I'm not much of a salesperson, you'll know how true that was because you'll stop thinking about me as being somebody selling you something.
Yeah.
I'm your guy. I'm your business partner.
Right.
And I have a large client in Western North Carolina affected by the floods.
Yeah.
The CFOs call me like, dude, what are we going to do with our health plan?
Yeah.
We have 1,000 people covered. Nobody's working for the next month. How are we going to resolve this? What are we going to do? And it's like, do CFOs normally call their benefit consultants to ask those questions?
Right.
No.
They don't.
They call me because they know that I am
You're a partner.
as much an employee there as anybody else.
Love that.
And I think that's the kind of trusted relationship. And it does get back to that fiduciary piece. If you're willing to say to your client, I'm here to help you.
Yep.
And I'm bringing my expertise. There's a million people offering great ideas. These 3 suck. These 4 are okay. These 2 will actually do something.
Right.
And I have vendors call me all the time, Ray.
Yeah.
Hey, well, we're doing this, and it's $10 a month, and we pay a 10% commission off of that $10. I'm like, okay, great. If I take it without commission, can I sell it for $9?
Right.
Well, I mean, you could. All right, great. That's more interesting to me because I'd rather tell my client, hey, this is $9. I'm not making any money on it.
Right.
But it's funny. There's so many hidden deals.
Oh, everywhere.
I have found 3 of the top 5 agencies who have, with almost every carrier in PBM, some kind of
backdoor deal.
Drug deal.
Yeah.
Bonus. All kinds of, and I'm like,
yeah. Well, I tell my audience, like, folks, those tickets to the Masters, those trips out to Pebble Beach, the Kentucky Derby, that shit costs money. Where do you think the money's coming from, and how much money are you leaving on the table?
Yeah.
And so I really admire that, honestly, David, like that business model and being transparent. I think it's underestimated, but it's so important because it's just a dirty business. And if you have a client and they understand where every nickel and dime is being spent, it's also very smart because it would be very difficult for them to break away from you. And it's not, folks, that if you've been with a broker for a long time, chances are you have more than just the business relationship. You consider them a friend. You maybe even consider them like an extension of your family. That's kind of the relationship, right? So it's very hard to break away from that. But you do need to take a look at what they are doing. You owe it. You have an obligation to your people, to your organization. Take a look at what they're doing. And I promise you, they may be wonderful people that you love to hang out with, go to a game, go to dinner, go to lunch, etc. But that person is likely not the person that's making the decisions that affect your options when it comes time for open enrollment. Those decisions are being made in the executive boardroom, and in that boardroom, they have a fiduciary obligation to their shareholders. And so what you're, suggesting, David, is that you're kind of flipping that upside down, saying we're not for everyone, but we do know our worth. We know what we put into this. And I will say for the record, it is much, 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 much more labor intensive and difficult to do the type of work that you're doing than to simply spreadsheet a bunch of options at time of open enrollment and just say, okay, you're going to pick the less of all evils, and we're here if you need us.
Yeah,
that's hitting the easy button by far. What you're talking about requires a lot of work, and I think done right, it's well worth the price of admission. With that, where can people find you?
So I'm ebenbenefits.com. I'm also on LinkedIn as David Curtis Smith, DAVIDCURTIS SMITH, and I'm heavily involved in ABIP, so it's not that hard to find me. I feel like.
Yeah.
The problem with a name like David Smith, you don't really always know what you're going to get. But I would say that I would. My cell phone number is always the best way to get me. 919-491-4321.
That's a good number, David.
It's a great number. When I went to Verizon, I'm like, I give you all $300 a month. You better give me a good number. This is like 1997. But I would say this, Ray, like as I would talk to people, my attitude, I have an attitude of prosperity with the knowledge that to be good, I have to also be selective and have a little bit of I've got to find the people who are good partners.
Yeah.
And I think when you have people who are desperate for your business.
Yeah. Yep. Desperation is the kiss of death in sales.
And
that's a book I haven't written yet.
You need to get on that. I'll contribute a chapter to it if you'd like.
Yeah.
But I would say that's the place that matters. If you've got somebody who, again, if you're doing large group, and by large group, I really mean like 100, 150, 250 plus.
Yeah.
And they have more than 20 clients in that, they're not doing the job. And somebody else is doing the job. If you got, like, I know for me with my self-funded clients, I'm looking at claims on a monthly basis. I've got some I look at on a weekly basis.
Yeah.
It doesn't take me a lot of time to do it, but I'm at least looking to figure out what's going on.
Sure.
And that's the thing I would say. If they've got a huge block of business and they're doing all of this and it's 100 plus size business, you probably aren't getting the attention that you need.
Mm-hmm. Yeah.
And so, and I'm not saying I'm the right answer. I'm just saying the truth of the matter is there are people out there who are really paying attention to their clients.
Yeah.
Who are really thinking about what do we need. And you can figure those people out pretty quickly.
Yeah, no doubt.
So.
Let's leave it there, brother.
All right, man. Thanks for your time.
I appreciate you coming and enlightening us. We've got to have you back, and you learn us a few more things next time.
Sounds great. Thanks.
All right, sir.
Thank you.
Have a great one. Till next time, folks. Love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.